Hello, I'm Dr. Julie, and I'm a board certified psychiatrist. And today I'm going to be talking about a typical day in my life as a physician who does utilization management. If you look back on this page, you'll see other videos where I talked about my non clinical career transition, some of my motivations for that, how that process happened, and also about what UM is utilization management. I'm going to call it UM for short in this video, what it actually entails. So, this video, I really am going to try to stay focused on what a typical day is for me. Now, before I get started, I do want to say that this is my own personal experience. It's my experience as a psychiatrist. There are physicians in all specialties. So this may, to a certain degree, more specifically apply to behavioral health or mental health. And then also my company has certain practices, certain guidelines that may be unique to it. And it's also important to know that I primarily review cases for Medicare. And so I do a few commercial insurance cases, but primarily I do reviews for Medicare. And so the guidelines that are going to be used for for that, can differ from what may be used for a commercial insurance claim. So I do want to make those caveats before I get started. So I work a typical Monday through Friday schedule. I work from 8 in the morning till 5 p.m. I do work from home full time. So, if that's not clear, I do work from home. It's a completely remote position. I have a small team. So when it's staffed, it really is about four individuals. Hopefully that will be expanding soon, but we have a small team. In our company, compared to the number of what we call physical health claims and non-psychiatric claims, the claims for mental health, like just the percentage of those is a lot smaller, which is why we do not work weekends and we do not take any kind of call. I do believe last year there's maybe like one or two occasions where there was like a Friday after a Thursday holiday where one of us worked, but in general, we do not work on any, of the major holidays that we're going to be off. Again, that might be different in other specialty areas where there are a lot more claims to be reviewed, and also just different companies may have different policies around call and working weekends. But currently, right now, I do not work any weekends on a scheduled basis, and I'm generally going to be off on all the major holidays. So, what is the day like? So, again, I start my day at 8 o'clock. Similar to what happens on medicine units, like in the hospital, the doctors typically round in the morning, right? They're doing all the business in the morning. And that's the same as it is on inpatient psychiatric units. So, typically, the mornings are a little bit slower because the nurses who send us cases are busy kind of getting all that together, getting phone calls, setting up times to do reviews. So I would say like between 8 and 10 tends to be probably more of the sluggish time. So that's going to be the time where I am finishing up any cases that I had left over from the previous day, checking emails, looking at my calendar, really kind of getting my day organized. If I already have peer calls that I'm scheduled to do from maybe the day before and I haven't prepped those already, then I will spend that time doing that. So that, usually keeps me pretty busy for that, hour and a half or typically hour in the morning where there's not as much scheduled things to do. That doesn't mean there won't be work to do. Sometimes we do have calls that are like start at 8 o'clock in the morning, but most often I would say that first hour, hour and a half is pretty slow. And that's when we're going to be doing the prep work and also any other administrative tasks. I try to take meetings during that time, etc. So what the actual work is we have an internal electronic medical record. And so I will open that and we have a queue, similar to any other kind of queue where you may see, a call center or any other kind of business where you're assigned cases. We call it a robot, but we have a bot kind of assigned that assigns us the cases. So as the nurses who in our company for our specialty, only nurses send us cases. So the nurses will look at the chart, review the chart, do a summary of like the pertinent things that we would need to know. For example, particularly in psychiatry, what medications are they on? What was the date of medication changes? Things of that nature. Again, I'm sure in other specialty areas they may prep cases too, but maybe adding different kind of pertinent information. And they'll send us the guidelines or criteria that they are using for that case. That is included in the write-up as well. And if it's going to be a case that involves us calling out to do a peer-to-peer call or review, it'll have the information for the utilization review person in the hospital who set up the review, and then also, the name, contact information, et cetera, of the doctor. In my case, it's going to be a physician, DO, MD, physician assistant, or NP. So that's typically who we will be doing our peer-to-peer calls with. So all that will be included in the case write-up that we go to when we open the chart. So basically, I will look at my queue. I definitely prioritize at least prepping the cases that are phone calls. So I will open those up first. I have a tracker that we use, so we put our cases there, and prep them. So when the phone call comes, we'll be ready. I know doctors who are on the other receiving end may not think so, but we really do try to get the information together and to be ready. We know that physicians who are seeing patients have a busy schedule, that these calls can be, disruptive to the normal flow of business. So we really do try to look at the chart beforehand, the summary from the nurse, any notes that we feel like we need to look at directly before the call, we'll do that. And, I try to have about, a 20-second or so summary of the case as I understand it, the medications and everything, to kind of introduce that when I first get on the call, and then really just ask the doctor to give me any kind of updates to kind of make it go as quickly as possible, because again, we know that they are, also pressed for time. So I will prep cases. There are some cases that I'm just reviewing from chart notes. Again, I will do those kind of second tier, based on the time that they're due. Most of the cases that are in our queue have a date and a time that they have to be returned by. So that, it is time sensitive, and things will also continue to come in during the day as you're working. So it's important to be able to like multitask. I mean, as it relates to what needs to get done first, what needs to get done today, what maybe can be deferred to tomorrow. For me, I really do prioritize like organizing and prepping the calls like first thing in the morning. Because if you don't, then it can get really busy during the day while you're trying to do the first initial review of the chart and also make these calls. So I do try to prep those things ahead of time. So I will do that. And then if there's no meetings or anything like that that I have to do, then I will start the paper cases, things I have left over from the day before. There is often something left over to be working on. And then I will start the peer call. So essentially, I will reach out to the NP, the PA, or the doctor, give the short summary, talk to them about whether it appears the documentation supports that the person meets medical necessity criteria for continued stay or not. If I'm going to be authorizing days, I will tell them. If not, giving them my reasoning, and then say, always advise them that they have the right to appeal. And then that ends the call. So I would say on a pretty typical day, I might do like 9 to 10 peer calls. On a very busy day, 15 or more peer calls. That would be like a really crazy day, having 15 or more in addition to the other work that you have to do. But I would say, between 10 and 15, pretty good. There's going to be a steady. There's going to be a day. 15 or more is pretty overwhelming. At least in the cases that we're doing, it can be pretty overwhelming. But that is literally how the day goes. So I'm either looking at notes and doing chart reviews and sending over, a short summary, a determination. We use templates that are already made. So there's certain required things that we have to fill out in there in terms of what our determination is. The determination is whether or not you're authorizing continued stay or not. Most of the reviews I do are for inpatient psychiatric hospital stays. Sometimes there can be a review for TMS, or they can be reviews for partial hospitalization programs. But that's primarily the things that I'm going to be making a determination on. And I think that it's important to recognize when you do start this role that you're not making any clinical recommendations. Again, as a person who's been on the other side of a peer review, I know that it can seem that way. But essentially, we are saying from an administrative point of view, does a person meet the criteria to continue stay at this level of care? That's kind of the whole point of the conversation. That'll come up sometimes. Sometimes the doctor will frankly ask me, what is the point of this phone call? And I just say that, like, we are just talking about medical necessity. I cannot tell them like what medicines to write. Sometimes if I do see something that looks concerning, that looks unsafe, I might, make a comment on it. We have some internal processes for when we see those things to refer them for quality management review. But in general, I do not, whether or not it's something I would do, whether or not it's in the standard of care, I generally do not make comments on what the treatment plan is unless I do see something that seems unsafe, or if I'm asked to. Sometimes, more often, like a nurse practitioner or a physician assistant might ask me a question about something, and I can, kind of give a thought about that, but I'm not otherwise like directing care. So that is basically how the whole day goes, and what I'm actually like physically doing is doing that. Sometimes I do get cases, what we call quality management cases. So the ones that are related to behavioral health, we do review those. So that would be a case where either a patient or someone acted on their behalf can make a complaint to the insurance company. Again, this relates to Medicare reviews because that's primarily what I'm reviewing. But they can make a report a complaint generally to the insurance company if they feel like they received unsafe care, if they didn't receive standard of care, if there was just some other issue that happened during their, again, typically it's going to be an inpatient psychiatric stay. So what a complaint might look like: feeling like they got the wrong medicine, a frank complaint about being abused, like physically, sexually, otherwise. It can be a person making a report maybe after a person has completed self-harm of any type or harmed another patient and there was a concern. So a patient can do it themselves or an agent acting on their behalf. And so basically what we will do is go in. Some of the cases happen in a behavioral health hospital, but they may not be behavioral health related. So for example, I reviewed a case about a person who had a lot of falls and there was a concern about the care that they got. So that itself isn't like a mental health issue per se, but it happened in a behavioral health hospital. So those will get referred to us. If it's something that is, I would say, more complicated medically, then I feel like I can really do, a good, honest review on. I might still ask one of the non-psychiatrists for either assistance or to take over part of the review. Maybe I'll review the part that relates to suicidality or self-harm, and maybe they can do the part that relates to diabetes if it's something that's complicated. I mean, if it's something pretty, kind of basic and standard, I will do it, but we do kind of work in conjunction together for those cases. So that is part of what I do. Those cases really come in just totally sporadically. Lately I've been doing, I would say, about one a week, which is definitely unusual because I've gone, I think, about maybe 4 or 5 months without even getting a case. We rotate them amongst each other. So those do come in, but it's just very sporadic. Sometimes it's more regular, like lately, and then other times it's not very common at all. Sometimes my day consists of different meetings. Sometimes those are committee meetings. Um, Sometimes we do educational, like seminars or lectures to the nurses who send us cases, to our internal auditors. People will request different topics. So for example, I've spoken on suicidality, I've spoken on bipolar disorder. So just different things related to mental health. So we'll get requests for that. And, when we have the capacity, it's been a little bit challenging lately because we've been a little bit short staffed. But when we do have the capacity, we will do, like these kind of seminars or these lectures about different topics related to mental health. But that, I always say, is primarily what my work day looks like. So mostly I'm going to be in my computer, in my queue, looking at cases. I'm going to be basically doing summaries, reviewing summaries, doing my own summary, talking to, healthcare providers about continuation of stay at various levels of care. I'm going to be doing some quality management reviews, committee meetings, and then, the educational outreach. And that's actually what the day looks like. I would say that I am at the desk most of the day. Of course, you can get up and walk around. My company does not monitor like clicks or how often you're on the computer. I do know that some companies say like you have to sign out when you go to the bathroom. You only get so many like breaks a day and things like that. At least at this point in time, my company does not do that. So you don't have to say like, oh, I'm going to be taking a bathroom break or I'm going to lunch or something. I mean, if typically what we do internally is if we're going to be gone more than an hour, maybe we have an appointment or somebody's running an errand to their kid's school or something and they think it may go over, we will let one of our other coworkers know so they can monitor our queue. Sometimes we do get cases that have what we call a quick turnaround time. Maybe the doctor's only available for the next 30 minutes or maybe the next hour. So, if someone is out, then you can just maybe go and pick that up and then just exchange another case with them when they get back. So that's how we have been able to work collaboratively, and it has really worked. So that way people during the day have like some flexibility to do things. I would say in our company, we have, like, for the physicians on our team, unlimited PTO, which has some positives and some negatives. I can probably talk about that in a different video, but I'm bringing that up just to say that that is one of the reasons why we don't have to log our time like by minutes and things like that, because we're not necessarily like signing out PTO time because we have unlimited PTO. So if you have an appointment or need to go to your kid's school or something like that, we just let each other know. We don't have to like sign out and keep up with it. So that is a benefit of working in this role. Again, not accumulating PTO can have some other kind of negatives to it, but hey, it is what it is in this role. At least for flexibility during the day, working from home, I found that it has been helpful. But that is a typical day of what I'm actually doing. So if you're, looking into utilization management and wondering what will I be sitting here doing, for me, that is how my day is structured. So if you do like this video, you found that it was helpful, please do hit the like on the video, subscribe to my channel, and press the notification bell. And I will be back with more information about transitioning to non clinical careers and mental health topics.